This year's ASH 2019 meeting, we've seen a lot of new developments and clinical data emerging in the field of immunotherapy in acute myeloid leukemia and myelodysplastic syndrome. It's really important to have a perspective. Just about 4 or 5 years ago, the immunotherapy field in leukemia was in an infancy stage. There was very little data, a lot of it that was being done at MD Anderson at that time at our institution. However, in the last 4 to 5 years, a number of studies combining different immune checkpoints, PD-1 inhibitors, CTLA-4 inhibitors, with epigenetic therapy, with chemotherapy are done. And this year there's actually a whole session on different immune checkpoint-based approaches that will be presented here. What we're seeing in general is that the combination of PD-1 inhibitors with azacitidine seems to improve the response rates over azacitidine alone. The improvement is not a major breakthrough at this time. We're seeing incremental benefit. What's really important is that when we do baseline biomarker evaluation, looking at T-cell infiltration in the bone marrow, cytokine production, we are actually able to predict and find that there are certain subsets of AML where there is increased T-cell infiltration, increased cytokine production, increased CD8 infiltration, and those are the patients who seem to respond best to immune checkpoint therapy. So I think just like we did for FLT3 IDH going forward, we're going to have to select those patients who have a favorable immune profile and then exclude those who have what we call immune desert kind of tumors. Also, what's also been very interesting and important is that in addition to the traditional checkpoints that we have learned from solid tumors like PD-1, CTLA-4, we have now started to identify unique specific checkpoints that may be important in AML and MDS. And two of those that will be presented here at the ASH meeting are TIM-3. This is an important immune checkpoint pathway, and there's early data showing combining PD-1 inhibitors, combining azacitidine with the TIM-3 inhibitor seems to improve response rate in both frontline AML, MDS, as well as in relapsed MDS situation. And so this is now leading to a randomized phase 3 study in MDS of azacitidine TIM-3 versus azacitidine, and there will also be a study in AML combining azacitidine and venetoclax with the TIM-3 to see if we can improve durability of responses, survival with aza-venetoclax. The other very important checkpoint pathway that was identified a few years ago, and there will be updated phase 2 data, is the combination of azacitidine with the CD47 antibody magrolimab. So the CD47 is a macrophage checkpoint. It's not like the T-cell checkpoints that we're used to, PD-1, CTLA-4, TIM-3, and basically it increases the activity of macrophages and allows the macrophages to infiltrate the marrow and attack the leukemia cells and also leukemia stem cells. And the phase 2 study that will be presented here at ASH shows that in frontline older AML patients, the response rate of azacitidine and the CD47 antibodies about 66% CR/CRI, very similar to azacitidine venetoclax, and it seems to be extremely well tolerated with early mortality rates, 90-day mortality in about 51 patients of 0. And this is a multi-center study ongoing at about 12 sites. We're also seeing some very encouraging activity in the TP53 set. Out of the 11 patients treated with TP53 mutation, 10 of them either frontline elderly AML or high risk or very high risk MDS have achieved a remission, and with the follow-up of 8 to 10 months, only one has relapsed. So this is all very promising, exciting, and we're also seeing MRD clearances in a number of these patients, and in MDS, cytogenetic remissions in up to 50%. So we believe that this could be one of the major immune checkpoint-based treatments. What's also interesting is that there may be a role to combining the CD47 antibody with PD-1, because one of the changes we're seeing in the bone marrow after CD47 AZA is increased T-cell infiltration, and a lot of those T-cells seem to have upregulation and increased expression of PD-1. So I think the field is actually now blossoming much more in the last 4 to 5 years. Preclinical data also is emerging, and we hope to continue the development into the next 2 to 3 years, and hopefully some of these will get to approval.